All right. Thank you so much for joining us tonight on our YouTube Live. My name is Debbie Jennings. I've been a nurse for 25 years, and the mission that we have is driving home access to care, health literacy, increasing it in all shapes and sizes all around us. And I am joined this evening by two amazing women that are rock stars in their community. Natasha, you may have recognized her. She and I have done a couple of YouTube videos before. If you haven't seen them, go watch them after this. They're amazing. And also by Kelly Bell, because I just love saying her name. And anyway, so Kelly, let me kick it off to you and Natasha. Kelly, start us out and tell us a little bit about you and your work that you do in the community.
Sure. So as Debbie mentioned, I'm Kelly McGlothen-Bell. I'm an assistant professor in our local school of nursing. Debbie and I are colleagues, and so we've had the opportunity to work together for several years now. We both have a specific interest and passion for health policy, and so I think that's kind of how we met. My background as a researcher has been primarily with mother-infant dyads affected by substance use disorders. So I've been a nurse for about 12 years now and focus primarily on high-risk populations in the birthing space. I'm also a lactation consultant, and that really drove my work looking at breastfeeding disparities amongst women with opioid use disorders. And really now I'm focusing more broadly in terms of how policies and structural factors may impede health outcomes or positive health outcomes for mother-infant dyads.
Love that. All right, Natasha, over to you.
It's so interesting. I'm so glad that we're doing this. So my name is Natasha Sobers. I am a full spectrum doula. Been doing this work for about 9 years, and also work for a larger company supporting families through pregnancy, birth, up to the point of birth remotely. So all over the country. And again, as Kelly was saying, a lot of the focus is around health disparities and wanting to bring more education and equity in different communities. I'm also a co-founder of the San Antonio Black Doula Collective, which is a collective of Black doulas working towards getting more doulas, more support in to the communities that need it the most. And I have a 2.5-year-old, so if she peeks in, you get to meet her. So being on the other side of it very recently, but having done this work, it's even driven me even more into what are the tangible things that we can do to improve our outcomes in the Black and Hispanic communities and empower ourselves and choose providers and locations that best support our needs and our health and just in general help people find their own voice.
So this is kind of the end of Black Maternal Health Week and the awareness around it. And we wanted to do something that kind of highlighted it. And I will be honest that the statistics around Black maternal health are abysmal. And, I mean, we see it and out in the community and what that looks like. And so much of it comes from advocacy, not having your voice. And, the statistics, these are straight from the CDC. Black women are 3 times more likely to die from a pregnancy related cause than white women. And I'm going to follow that up with another CDC statistic that blows me away when you pair it with this one, is that more than 80% of pregnancy related deaths are preventable. And when we look at our mortality rates across the nation, and when we are vying for first place, not in a good way, with third world countries, with our maternal health outcomes, I mean, we have got to do something. And where have you all seen in your work, and Kelly, I'm going to start with you. I feel like there's something around the conversation, right? Like, what can we have as a conversation starter so that women walk into knowing that, yes, oh my gosh, I'm pregnant. Now I need to go get help, because so many women will show up at the point of giving birth is the first time that they'll see somebody, right? And then we've got, to worry about, are there STIs on board? You just start worrying about all that and not less to know that, listen, you have not received the maternal health care that you need along the way. And so where is it that we can kind of find advocacy in those conversations with women to make it a normal part to say, I'm pregnant, let me go. And then also, because what I hear is that women feel they don't have a voice
Mhm.
in the provider's office. And I my heart breaks knowing that. And my heart breaks knowing that the reason we have so many outcomes that are going down the way they are is because of the advocacy and not having your voice. So I
Yeah.
probably asked you a really long wraparound question, but I'll ask that to both you and Natasha, is kind of where do we start even having that?
Yeah. You know, when I think about some of the health disparities that we're facing as it relates to Black maternal mortality and morbidity, this isn't something new. This has been happening for decades. I remember being like a preteen, this little nerdy girl watching a PBS special that was specifically talking about health disparities in America. And it was like 10 or 12 or around then. And, for the life of me, as I was watching this video, I just found myself getting upset hearing the disparities and hearing the statistics that you just shared, that and knowing that regardless of how much education I attained, like I was still more likely to die during pregnancy or in childbirth the year following, as my white counterparts. Regardless of how much educational attainment I had, and as someone who knew I wanted to go into nursing, I wanted to obtain higher education. That was troubling, and it should be for any woman. Like, one woman loss is too much, but that just stuck with me, from the time I was a teenager. And then as I got into nursing school, I remember like being told multiple times, and it was regardless of maternal mortality, but across like health conditions, that being Black was a risk factor, for these different conditions. And I was like, that is not sitting well with me. Like, I'm not understanding that. Like, and no one could really, help me to understand that. But that was something that kind of perpetuated my education. And I think that language that we use within nursing schools, within medical schools, perpetuates and carries on into the healthcare setting. And so providers are still acting like this and almost putting the blame on patients, saying that, having this misconception that it's your fault that you're coming in with these conditions. You should be doing better with your health, versus looking at the bigger picture of saying, what are these systemic issues that people are facing that are precluding them from attaining the health status they want, and that they deserve to have. And so as a nurse and as a nurse educator, that's one thing that I really try to hone in with my students, is that you have the power to make a difference for these patients. And the way you show up for them dictates likely oftentimes their health outcomes. And so if you're treating them disrespectfully, if you're coming in with bias, if you're coming in with stigma and not acknowledging that you have it, because we all have it, but if you're not acknowledging that you have it, that's the first place to start for the students that I tell them, with helping to eliminate some of these health disparities that we're seeing.
Yeah,
And what about you, Natasha?
yeah, I love what you were saying, Kelly. And from the provider aspect, right? That was exactly what I was going to say, is that so much is put on the patient, and the patient is the client, patient, whatever. They're expected to either one, just follow along, and they're not educated.
Mm-hmm.
And they're expecting their providers. When I'm talking with people literally all over the country, they're like, I thought my doctor, I thought my nurse practitioner, what have you, was gonna give me more information. I don't even know where to start, right? And so that's where I start. I'm like, how is your conversations with your medical provider? How are you feeling? Is your gut telling you that they're not listening to you? And then I go a step further, and it's like, we have to really look at the birthing environment. Are you going to a hospital? Are you choosing a hospital because that's just what people do, or have you educated yourself about the different options and what really resonates for you and what feels the safest for you? And because in most cases, the doctor or the midwife at the hospital is not going to be the person that you've been dealing with, is not going to be the person that's on call. So you really left up to the nurses, right? That are there, as well as the providers. And I've worked, in several of the hospitals here in San Antonio, and I've seen the same group of nurses working under an OB care versus midwifery care. And often it's whoever the lead medical provider right? That's going to dictate how those nurses are going to support. Of course, there's always the badass nurses that are just like, whatever, like I'm here for you, I'm gonna advocate for you. But we need more of that, right?
Mhm.
And so I think in general, nurses have historically been that voice. And in recent years, I feel like because there's so much put on them, it's they don't have time to do that anymore.
Yeah.
So it falls to the patient, it falls to the clients to
Yes.
educate themselves. First starting with like, what is the birthing location? Do we know the statistics of cesareans? Like very basic across the board. Episiotomies, early inductions, ask your doctor the same thing. And then we go into, okay, so now that we have this like baseline, right? Do we change locations? If there's not a good location near you, then what can you do, right? And really the biggest thing is educating ourselves about what our bodies can naturally do, right? And so often when I'm talking with parents, Black parents, they're like, I'm really scared of dying. I'm really scared of, this or that. And I'm like, hold on, let's just start with, let's learn about our body. Let's make sure that we have all of the things in place, because then at the end, when it comes to the labor, when it comes to postpartum, when your doctor says or your midwife says, we need to do this procedure or give you this medication, you have full 100% trust that they are listening to you, that they're doing it not just in your best interest. I think in most cases it's in the best interest, right? But that they know you as a person and aren't just going by the textbook or what they learned, and really practicing evidence-based information. If we start there, then I don't have stats, right, for that, because we're not looking at those, like now we're looking at those things, but there's a dramatic decrease. Let's just say with doulas, right? When people are working with the doula, that is most of what we're doing, is providing that education and facilitating conversation between the medical provider and the patient. And we know that this works. We know that it drops significantly the rates of cesareans, morbidity, mortality, right? So if you start again with the medical provider, is this the right fit for me? Even if they've been your GYN for the last 20 years, they were your mom's GYN, whatever, are they still the right fit for me? And do they understand the dynamics of me being a Black person, me being an immigrant, me being a Hispanic, me being, having different abilities, right? Do they understand what that means for me and my care? And if we hit it from both sides, right, educating patients, moms, parents, and then encouraging medical professionals to really sit back and like rehumanize us. Like you're not working on cadavers anymore. These are real people, and we're trying to avoid that, right? So if we can hit it from both sides, that's like where we start. And I think there is a lot of work being done in pockets, but it now needs to be like systemic, right?
Yeah, I love so much of what you said, Natasha. I think to err on the side of caution, like that's what we do as providers, right? And I feel like now it's great that we're bringing so much awareness to these health disparities, but as we know, like it can cause fear. And I feel like we've gotten away a little bit from the celebration of what it is to be a mother, to have the baby, to have a pregnancy, and to be able to celebrate that. And I really love when I'm able to like learn from doulas, because there's so much knowledge that you hold as a provider. You empower families to be knowledgeable and advocate for themselves as well, and to be able to celebrate that. And I think that's something that we as nurses, we as healthcare providers can really take hold of, because you kind of alluded to this, but we almost learn to look for those abnormal findings, and it becomes very medicalized very quickly. I mean, we have to learn to celebrate and recognize, that this is a life experience for someone that they're going to take hold of for the rest of their lives. And that plays a really big part in their perception of birth and what does that mean to be a birthing person.
And then in parenting, right?
Yeah. So you both have mentioned systemic. And I want to go a little deep, and don't be afraid to make it uncomfortable. And because I think sometimes we get afraid to be uncomfortable. And these are conversations we need to have. At a very face value, and Kelly, I'll start this off with you. What are the reasons? Is it biological? Is it lack of advocacy, lack of literacy, whatever that is? What are the main reasons that we have the rates that we do? And where are, is it from making sure that, do you know your family history? I know Natasha digs into that a lot. Do you know your family history, right? When you come in, and the work that you do, and don't be afraid to go uncomfortable with it, because I want it to be a really raw conversation about, like, this is what we're seeing on the streets and nobody's listening to us.
Yeah. I think, it's really easy to go back to the biological aspects. And like I said, that was the way I was taught, like being a Black is a risk factor. But at the root of it, it's racism. If we look across systems, that's what it is. We have to call it out for what it is. People don't show up to the healthcare provider solely, strictly based on genetics or biological factors, but largely they're the sum of all of these different social drivers of health. Are they able to access clean drinking water? Do they have access to food? Are they living in an environment where they feel safe and protected? I think all of these things play a major factor. And when we don't acknowledge racism as a root cause of these health disparities, we're doing ourselves a disservice and we're truly lying to ourselves. And you have to ask the question, if we know that it's racism, because it's coming out more and more nowadays, why are we not changing it? And why are people not being held accountable for their actions?
What do you think, Natasha?
Repeat the question one more time. I got lost in
Yeah. No, as far as where do you see is the base problem for our outcomes?
Yeah. So echoing what Kelly was sharing, when I have two members that have very similar outcomes, right? And you ask, and I say members because of the work that I do, when I have two clients, two parents that have very similar outcomes, and on the surface, it seems like everything was the same. But when you start to ask questions, did you have someone there with you that could also advocate for you, right? Did they ask you questions? Did they answer your questions? Did they listen? And all of those things can create a situation where, yes, it was a healthy mom, healthy baby, and we always think about like mortality, but what about the morbidity, meaning the injury, right?
Mm-hmm.
So again, on paper, two people can have the same outcome or similar birthing experience, but when you start to ask a lot more details, it's in who was caring for them, how they were cared for, were they listened to, and all that goes back to what Kelly was saying: racism, bias, bigotry, and also I'm starting to learn more about epigenetics, right? Racism stemming back generations. We know this in Jewish populations that their families or ancestors, right, historically they dealt with, they went through the Holocaust. They see that genetically they have their offspring, the genetics has been altered in some way because of the level of stress and trauma, right? So not just physically, but then also emotionally, mentally. And I often talk about with my parents, with my clients, about this, like, yes, you are predisposed, but it's not just about like you just walking in because you're not doing the right. You could do everything right, but what does your family history look like? Has your family been here for generations? And we have to factor that in. That's just going to predispose you. And that's not your fault. That just means that your medical providers need to pay more attention. Mm-hmm. That also doesn't mean that paying more attention means if you don't do this thing, your baby's going to die, right? There's so many nuances. And on the flip side, my family, we're immigrants to this country, and I work with a lot of people that are from different African countries, and they're like, oh, my doctor was like, oh, I'm predisposed to preeclampsia, this and that, because I'm Black. And I was like, okay. So let's talk about this other stuff, right? Like, historically, has your family had to deal with these things? Did your grandmother have access to, Whole Foods, right? Did they have organic foods? Did they have, more processed foods, right? So all of this is not just today. It's coming from before. So that's like where it's coming from. But now what do? We educate ourselves, we try to eat better. And also the providers have to listen when they say, I had a member just a few weeks ago. She went in for a cesarean. It was an unplanned cesarean. And she kept telling the anesthesiologist, I can feel everything. Yes, I'm numb, like I can't pick my leg up, but I can feel everything. And they started the surgery and they kept going, right? Until her doctor was like, well, first the doctors just shouldn't have started in the first place, right? But at some point the doctor stopped and was like, I'm going to listen to my patient. You need to do something, right? And so I bet the doctor wanted to say something before, but because of the way the systems were and whatever, there was more to the conversation, but they didn't follow their gut and advocate for their patient in that moment. And they waited. And so now the patient lost their trust in the doctor that they really liked before because of the way the dynamics, the whatever was going on, I don't even know what to call it, between the anesthesiologist and the OB. And so not listening, a lot of the cases that we see on social media right now, they were educated, they were healthy, they had partners that were advocating for them, but the medical providers weren't listening when they say, hey, something is wrong, or dismissed it, or chalked it up to something being, not that big of a deal. This is like on a completely different topic, but I was just looking at something and someone was, she was white. No, she was Hispanic, but I guess her children are biracial. And when they went to the pediatrician, they were like, hey, my daughter, she's exhibiting a lot of like signs of puberty. It's like, oh, well, Hispanic and Black children tend to go into puberty a lot earlier. Sure, yes. And then when you go into the comments, every person that said, yeah, I started at 7 or 8, they ended up with like endometriosis or PCOS or some other thing, right? That now shows why they started the puberty earlier, and their providers weren't listening. So yeah, we're talking about maternity, but even from the early onset of our reproductive health, we're being dismissed.
It's that life course trajectory. And you bring up a great point. Like we're seeing, we see it more and more. And it saddens me every time we see another person, who's passed away during that period. But then we also see, celebrities coming out and telling their stories about how they weren't listened to. And again, you start recognizing that this isn't just a poor person's condition. This isn't just someone who's using substances. Like this happens across the board to people, and there's a reason for it. And that reason, again, goes back to, how are we providing care in our clinics and in our, in our spaces? What type of respect are we offering to people? We know that there are epigenetic factors, as you mentioned, Natasha, that again, oftentimes are rooted in a lot of these system-based issues of, access to healthy foods, access to water. We talked about these things. But, as they're going into the healthcare setting, again, they're being perpetually dismissed, as you mentioned. And that crosses, again, socioeconomic barriers, and particularly for Black and Brown people. We're just continuously seeing that it's not stopping, it's not ending. And so the next question is like, what do we do?
And also it doesn't just stop at childbirth. And that is, a really big piece of the conversation as well. And I think so often we're like, oh, okay, you had your baby, you're good to go. And I believe the number one reason for Black maternal death is sepsis, is what I've looked at. And so when you're like, okay, the reason why it was so important, in the state of Texas, we just extended, we don't have, for those of you who don't live in Texas, we don't have Medicaid that's expanded, but they're doing little pieces of it. And a little piece of it that they've done is to extend the Medicaid for women who have had babies up to a year after birth. And that's so important because that still qualifies as a postpartum death, even though it is, you know, a year after, and people are like, well, you should be good. But there are so many things that can happen around infection, around, you know, with breastfeeding and just all that. And so it's really the advocacy. I cannot emphasize enough how passionate I am about it. And I received a call from one of the girls that I work with not too long ago, and just probably about 2 months ago. And I actually, and she said, Debbie, she said, I had a really bad, and she's African American. She said, I had a really bad experience with my first baby. She said, he kind of said, oh, you might be preeclamptic. And now she's pregnant with her second baby. And she was having all the signs, like everything she was telling me. She's like, I don't feel good. And she was actually living in a homeless shelter at the time. And I was like, get to the emergency station now. Like, tell me what your blood pressure is. But she is not afraid to speak up, but she doesn't feel like she can. And sometimes you're at the mercy of, especially if you don't have a good provider, you're at the mercy of whoever you're gonna walk in the door and see. And I just, I want to be able to change the conversation to that young girl who's sitting there and saying, you know, I don't know how to advocate for myself. And we do a lot of role plays in the workshops I do, like, you know, when you go talk to a provider, this is what you do. And so what are kind of some top level, you know, advocacy tips that you can give to that person out there? And honestly, they can be young, they can be older, it can be anybody, like not knowing what that looks like when you go in to advocate for yourself.
Yeah, so while she's quiet, the first thing I like to
She's obviously advocating for herself, your 2.5-year-old. I love it.
Very much advocating for herself right now. On two fronts. So doulas, we like to use this acronym called BRAIN. Literally use your brain and figuratively. And I tell particularly partners, like, even when you don't know what it is you don't know and don't know what to ask, but also for if you're the birthing person, you can read all the books and a different scenario comes up and you're like, so what are the benefits? What are the risks? And what are the alternatives? And I encourage people to start doing this from early in pregnancy. Like even for like routine scans, so that you know and you understand what they are, whether it's a vaccine, whether it's a scan, whether it's a procedure. What are the benefits? What are the risks? What are the alternatives? And then I say, go back. What are the benefits and risks of those alternatives? And so then you sort of have more information at your plate, right? Because you could have one provider that approaches whatever's going on one way, and like 3 other ones that are like, well, we would actually do this, or we would like to wait and see, or we would like to try this. And then what is your intuition telling you based on all of the different options? And then the last is the end is no or nothing. What if we do nothing? No is a complete sentence. Especially if in your gut, in your heart of hearts, you're like, this does not sound right. You want to induce me at 37 weeks because my baby might be too big, but everything else is okay. You might want to induce me at 37 weeks because my baby is too small, but everything else is okay. Like, I need a medical reason and I need a diagnosis so I understand why you're doing this thing. What if we do nothing? What if we do more testing? What if we do more screening? And so using that BRAIN acronym, anybody can use at any point. I've had dads, I know there's a dad that a few years ago, his mom was sick and he was like, man, I'm going to tell my mom, you know, to do this when she's like dealing with, you know, her doctors and things. That's there's a lot of different things, but I think that's one thing that I always make sure that I end the conversations with, especially if it's the first time I'm talking with somebody.
So go through the acronym.
Yeah. So B is for,
I'm gonna also put it in the show notes too,
yeah,
so that people have access to it.
So B is for benefits, R is for risks, A is for alternatives, I is for intuition. What is your intuition telling you? And N is either no or do nothing. So BRAIN, brain. What are the benefits? What are the risks? What are the alternatives? What is my intuition telling me? And what if we do nothing right now? Or what if I say no? Don't break my water.
I absolutely love that. I hadn't heard that acronym before, but I think it hits on all those major important parts of advocacy, and acknowledging and understanding, what are your non-negotiables, what makes you feel comfortable, and most importantly, as you said, trusting your gut and understanding if something doesn't feel right to me, I know myself best, and maybe I can't exactly articulate what it is, but just acknowledging that something doesn't feel right, and being comfortable or being able to speak up on that. I think is super important, that trusting your gut aspect. Is so powerful. And just knowing that patients and clients have the option, to fire their provider. They don't have to remain with the same person. If they're not feeling comfortable or respected by that individual, they can go up the chain of command. And it doesn't make you a difficult patient, it doesn't make you a difficult client. I know I'm a people pleaser and I hate to, you know, ruffle the feathers, but when it comes to your health, sometimes that's what you have to do. And so it's okay, if you need to fire that provider, in that instance. And if all else fails, I always ask, document it. If I've gone through all the brain aspects, and you're still telling me this is something that needs to happen, I need you to document that these are the questions I asked, and this is the step that you decided to take.
What is something that you want people to know about Black maternal health? And it could be anything general. Is it something just from the experience you have, or, as a woman, as a provider, just anything at all? I know it's a very global question. And I'm getting a lot of text from people that are really enjoying the conversation. And so I'm excited because I think that we could go in a million different ways with this conversation. And I know, Natasha, one thing that I'm going to ask you that question is, what is the one thing that you want to talk about? And I'm also going to follow that up with a question of, give me 3 tips of what you would want that woman to know right now who's pregnant. So we'll start with anything that you want me to know about Black maternal health. And it can be a statistic, it can be anything.
Yeah, we have really beautiful, wonderful birds.
Oh,
I had one. And right here in my home with a midwife, I 1000% trusted San Antonio nurse midwife. I'm gonna botch her last name, but Nikki McCleaver. I've known her for years. Nikki Brown. We have beautiful birds at home, at birth centers, and in the hospital. And if you are wanting to, and it's not just about how you birth, actually. Um, I could have ended up transferring. I could have ended up in a cesarean. And I know that every step of the way, I would have been supported and heard and listened to. And I had my people around me. And either way, it would have been beautiful because of that. Right. And then 3 tips. If you can, always have someone with you when you go to an appointment.
yes.
And
dive into that a little bit more, Natasha, because
yeah.
I was talking with a friend of mine last night, and he was telling me about a patient that they received. And when you're in a crisis situation, all common sense goes out the window, right? And like, even we were talking about the fact that they totally blanked. He was telling me they blanked on, how do you call 911? They were calling 311. I mean, they just, like, literally all common sense goes out the window. So if you could dive into that a little bit more, because having that second person there, having a notepad there, having something. So just talk about that, expand on that just a little bit.
Yeah, having someone there that can, 2 brains are better than one. White coat syndrome is real. I experienced it postpartum. I walked into a primary that I hadn't seen before, and I was just like, yes, okay. And I walked out, and I was like, wait, what? Let me dial it back. What is happening, right? White coat syndrome is real. So writing down a few questions ahead of time. Also having whoever's going with you write some questions down. Whether it's their child or not, right? Like, if they're there with you, they're invested in your health and making sure you're okay. What questions, even if they sound super dumb to you, they're not dumb. Ask the questions. And having someone else there can help you we sometimes we hear things and we misinterpret it, or we hear things and we doubt ourselves, like, did they just say what I think they said? And you can have that like second person to be like, yes, girl, or maybe you need to go take a nap, because that's not the conversation that was having that you were having, right? And so much happens in pregnancy to our brain, without any like previous life trauma, without any of that. A lot happens to our brain with hormones as it is. And so retaining information, being in a space of just being in a hospital or in a clinic with someone that you may or may not be comfortable with, sends our body into a fight or flight response, right? And so it's hard to retain information. And again, having that second person can be really helpful. And then hopefully that same person can be there with you throughout labor and throughout birth. Again, fight or flight response can literally shut down the labor. I've seen it happen. I've seen someone progress to 3 or 4 centimeters, and then a few hours later, they were back at like a 1. And so having that continuous support throughout just gives you emotional support, mental support, also physical support. And if you have 1 or 2 people that are coming with you right to appointments, they can also be the people that are checking in with you postpartum. Hey, remember when the doctor talked about this? Hey, the medication, hey, and they at that point hopefully will know you best. And so if something comes up during the labor and birth, they can say like, hey, in the appointments, this is what they talked about with their provider or their doctor, right? And so that's one. Number 2 is know that there are a lot of really good obstetricians out there. And there are a lot of really bad ones too that don't listen, that don't do all the things, right? And so shop around, just like we shop around for our internet and our cars and even the schools, right? Or the best deal on the latest brand, whatever. We shop around until we find what works for us, and know that as far as insurance, even if you have private insurance or insurance through your employer or what is it? Which one? I always get them confused. Medicare?
Medicare, Medicaid.
Yeah, that.
Yeah, Medicare's for the older.
Okay. Medicaid. So you can see a different provider for every appointment and it would be covered, right? So if you started off at week 7, week 8 with one doctor and you were like, that's not, you go to another one, nope, that's not, it will be covered by insurance if they're routine, checkups, right? Some providers do consultations, or you can, just request an appointment, right? And pay the $20 copay. It is worth it, 20, 30, whatever your copay is. And along with that is, and this may be my third one too, but know that you have different options as far as medical providers. There are obstetricians, there are nurse practitioners, there are midwives, both in hospital settings and out of the hospital. You don't have to necessarily do a home birth. Maybe you do it at a birth center, or at a hospital that has the birth center, especially if you are already truly high risk. You want a more holistic approach to your care, but you need to be in a hospital setting. That midwifery care can be an option for you. Just find the right hospital, all those things, right? And that is going to be my third one. Some of us cannot birth at home. Some of us cannot birth in a birth center. There's a very big movement right now for everybody, for a lot of people to be like, just do it at home. Just do it with your doula. Just do it with doulas are not medical professionals, period. Oh. We can advise you, we can educate you, we can support you. Some of us have been around the block enough to be like, something's going on, but we cannot diagnose, we can't do any of those things. So if you want a home birth and you want to be in a birth center, seek that out in your hospital, right? Seek that out. Does the hospital have labor tubs? Can I have intermittent monitoring or wireless monitoring? I may or may not want an epidural. Maybe there's nitrous oxide. Maybe there is other pain management options for you to still have a safe birth and still have a crunchy birth or what have you. And if you don't know what I'm talking about, connect with a doula, right? Do your research, right? There is a few websites that I would recommend checking out. Evidence-based birth, Spinning Babies and Mama Natural, and also a book called Nurture by Erica Chivi. She's a doula. She's amazing. She's a boss, has a reproductive health center out in LA. She has a lot of content and information out there as well.
Great. And I'm going to put links for all that in the show notes as well. I will tell you, I love that you emphasize that you don't have to have a home birth. I will be honest, I feel like it looks really beautiful, but I don't think I would embrace it. I'd be like, oh my gosh, the bath is going to overflow. I'm going to like spring a leak on the floor. Like, I just feel like I would not embrace the beauty of it that it would. So thank goodness, you know, my son is 27 and, you know, we're all surviving. So, but Kelly, over to you. What is one thing that you really wish that we knew about and around Black maternal health? And what are 3 amazing tips that you have? And Natasha, I've been taking notes with everything you're saying. So thank you for that.
Well, I appreciate everything Natasha has said, and I feel like I'm a little discombobulated because I'm just soaking it all knowledge
Yeah.
in. And so forgive me if I don't answer your question completely. I would definitely, again, just emphasize that birth can be so beautiful. This is a beautiful time in a person's life that should be celebrated. But I also think it's important, and we kind of alluded to this a little bit earlier, is to recognize that this doesn't start at the hospital or at the birthing space. This starts very early on. We talked about puberty for young girls. We have the power to advocate for changes in policy as it relates to health for not just Black people, but people of color, people in general, specifically thinking about starting from sex education in school. I'm not sure where everyone's from, but in here in Texas, we can't provide comprehensive sexual health education. And I think that does us a disservice in terms of recognizing and preparing people for their sexual and reproductive health as they continue to age. We do a horrible job of teaching people about the various conditions that can happen over their lifespan. So we move forward with this fear-based education of don't get pregnant, don't have sex, abstinence only, versus teaching people about contraception, teaching them about safe sex practices, recognizing that there is another side of reproductive health, looking at infertility. And infertility, largely affects people of color at disparate rates as well. And so not understanding that, it precludes us from being able to ask those questions as we get older and as we're entering OBGYN offices and whatnot. And so I think identifying and being aware that it starts very early on in terms of our health and that trajectory continues on as an adult. And then recognizing that we can advocate for certain bills as relates to things like sexual health, as relates to coverage for doulas, lactation support. There is power in numbers. And so when we're aware of the power that we have, we can make a big change. And so, identifying places that you can go to partner with different advocacy groups. The San Antonio Black Doula Collective is a wonderful organization. I've known several of the doulas there, and they do wonderful work. And so finding these community-based organizations is a great way to partner and understand that, again, we have a voice, we have the ability to make changes happen, but also understanding where those changes need to happen. And that often comes from the power in the mouths of the people who've experienced, these disparities. And so, again, going back to, what Natasha said, listening to people, listen to Black women when they tell you what they need. When you're asking them, what do you need? What kind of policy do you need? What kind of research do you want us to do? Like, ask them and be willing to listen and act on what they tell you. That's something I really try to hold true to in research. We talk about evidence-based care and randomized control trials being the gold standard, but why isn't the lived experience of the people who are experiencing these issues evidence-based care? Why is that not informing what we're doing? And so I think that that's a major place that we can advocate and collaborate on. So yeah.
I love it. I'm like you, Kelly. I'm kind of like soaking everything in right now. And I am just beyond grateful that we were able to gather and have this conversation. And I feel like there are so many other conversations that can come out of it. And so again, for everybody that's joining, thank you so much for listening. Don't forget to like, subscribe, and we will drop a lot of information in the show notes for you, links to items and also to the book that Natasha recommended and to the websites as well. I think there's a lot of work to be done, and being able to advocate, being able to get out there. And I love what you said about listening, listening to what they need and acting on that. And I think it breaks my heart when, you know, you have so much research eliminated women anyway, right? And then you take that into marginalized populations and it gets, the funnel is even smaller. And, you know, I mean, not to mention the conversations around menopause and, you know, I mean, the fact that control trials were done with women in their 60s and they weren't listening to like women in their 20s, 30s, 40s who are really experiencing things. And so um, I'm grateful that you all are welcoming the conversation and opening a lot of doors for people to hear about it. So incredibly grateful for the time. And for everyone out there, please stay safe and stay well, my friends, and we will connect for other times as well. So have a good one. Thank you.
Thank you for opening the
Thank
stream.
you.
Bye.